Hello everyone. So today we would start the topic of lumbar region. In this lumbar region, we would first see the borders. What are the borders? Superiorly, we have 12th rib. Inferiorly, there is iliac crest. Laterally, there is Lesgaard's line, which is vertical line passing through the end of 11th rib from the mid-axillary line. Okay. See, superiorly, there is 12th rib. Okay. 12th rib. Inferiorly there is iliac crest, okay, and laterally there is vertical line passing the end of 11th rib from mid axillary line. Okay, according to erector spinae muscle, the lumbar region is divided into medial and lateral. Okay, erector spinae muscles are these. Okay, if we divide this according to this muscle, lumbar region are medial and lateral. Now what are the layers? Skin is thick, subcutaneous tissue. There is superficial fascia and deep fascia, proper fascia. Superficial fascia is divided into fatty tissue in gluteal region, which is called as vas adiposa lumboglutealis. There are 2 to 3 layers. Proper fascia forms a sheath for erector spinae muscles called as fascia thoracolumbalis. Now this erector spinae muscle is covered by a sheath called fascia thoracolumbalis, and it is divided into superficial and deep groups. Fixed as spinous process and deep are at transverse process. Superficially, this it is fixed to spinous process of vertebrae, and deep group it is fixed to transverse process. Now muscles are superficially there is latissimus dorsi muscle. Deep are two groups, medial and lateral. Medially there is psoas major and minor, quadratus lumborum muscle. Lateral group there is external oblique, internal oblique, transverse abdominis, serratus posterior and inferior. See. Now superficially there is latissimus dorsi muscle. Now deep there is medial and lateral. Medially there is psoas major, psoas minor and quadratus lumborum. Okay. And laterally there are deep. Which are those? Serratus posterior, inferior. These are serratus posterior inferior muscle. External oblique muscle, internal oblique muscle and transverse abdominis. Now there are some weak places. It is very important to remember these weak places. What are those? First is inferior lumbar triangle, which is petit triangle, and superior lumbar triangle, which is Greenfeld triangle. What are borders of this triangle? Petit triangle, it is located here. So according to this, externally there is external oblique muscle, which is also called as laterally. Laterally or externally there is external oblique muscle. Medially there is latissimus dorsi muscle. See, medially this is latissimus dorsi. Laterally there is external oblique muscle, and inferiorly there is iliac crest. External oblique, latissimus dorsi and iliac crest. Fine. And floor, it is covered by internal oblique muscle. Superior lumbar Greenfeld triangle. Now in this, superior medially there is serratus posterior inferior muscle. Okay. Inferior medially there is erector spinae muscle. Roof is by latissimus dorsi and floor is by transverse abdominis muscle. Okay. See. And also superior laterally there is 12th rib, inferior laterally there is internal oblique muscle. So once again we would revise: superior laterally 12th rib, inferior laterally internal oblique, superior laterally 12th rib, inferior laterally internal oblique, superior medially serratus posterior inferior, inferior medially erector spinae muscle. Roof is by latissimus dorsi, floor is by transverse abdominis. What is clinically important? It is important for herniation. It is contain fat where abscess and phlegm tends to occur. Now what are the arterial supply? Lumbar artery, branches of abdominal artery. Venous is lumbar vein, which drains into inferior vena cava. Nerves is subcostal nerve, posterior branch of spinal nerve. Now we move on to the next subtopic, fascia and fatty layers of retroperitoneal space. Now first is renal fascia. Now this renal fascia is divided into pre-renal and retrorenal. Pre matlab before, retro means behind. Okay. Now between this pre-renal and retrorenal there is paranephron, which is adipose capsule of the kidney is present. Now this paranephron, when it continues to kidney, inferior to the kidney, it continues to parauteron, which is a fatty layer surrounding the ureter. Okay, paranephron, which is adipose capsule of the kidney present, when it continues inferior to the kidney, it is called parauteron, which is a fatty layer surrounding the ureter. Fine. Now there is one Tolditz fascia, which separates the retroperitoneal fat from paracolon. Okay. Now in this diagram, if you see this ninth color, it is called Tolditz fascia. See this. Fine. Next is retroperitoneal fatty space. Retroperitoneal fatty space, anteriorly there is parietal peritoneum and posteriorly endoabdominal fascia. Now see this area in this photo, this area is retroperitoneal fatty space. Anteriorly there is parietal peritoneum and posteriorly there is endoabdominal fascia. Paranephron. Paranephron anteriorly is prerenal fascia, posterior retrorenal and internally parauteron. As I said already here, paranephron is between prerenal retrorenal. So anteriorly would be prerenal, posteriorly retrorenal, and internally there would be inferiorly there would be parauteron. This is inferior, sorry, not internal. Next is parauteron. Anteriorly there would be preuteric fascia, posteriorly retrouteric. Now this parauteron, it is a covering of ureter, right? So in ureter there would be preuteric, retrouteric. So anteriorly would be pre and posteriorly retro, simple. Paracolon. Anteriorly retrocolic fascia, posteriorly retroperitoneal fascia and superiorly transverse colon. Now in this picture, see this is the last one, which is paracolon. Okay, this one, 13th. So anteriorly would be retrocolic fascia, anteriorly would be retrocolic fascia, posteriorly would be retroperitoneal fascia and superiorly would be transverse colon. Just remember, a paracolon is below the transverse colon, transverse mesocolon. Now we move on to the topography of vertebral column. Vertebral column, its morphology is 7 cervical, 12 thoracic, 5 lumbar, 5 sacral and 2 to 3 coccygeal vertebrae. Now there are two curvatures, lordosis and kyphosis. Lordosis means anterior convex in cervical and lumbar region and posterior convex, which is kyphosis, in transverse and sacral. Anteriorly convex in cervical and lumbar, and posteriorly convex means from posteriorly if we see convex, then it is thoracic and sacrum. Function: supporting the body weight, protecting the spinal cord. Now there are various ligaments. Okay, which are those? Ligamentum longitudinale. See, ligamentum longitudinale anterior ligament. Okay, anterior longitudinal ligament, which is anterior part of the vertebral body. Next is ligamentum longitudinal posterior. Ligamentum longitudinal posterior part of the vertebral body. Ligamentum flavum. Ligamentum flavum is the space between the arch. Supraspinous ligament, tip of the spinous process of lumbar vertebrae, like two adjacent vertebrae. Spinous process of lumbar and thoracic vertebrae. Interspinous ligament passes between the spinous process of two adjacent vertebrae. Okay. Ligamentum nuchae. Ligamentum nuchae is continues from ligamentum supraspinale along the spinous process of the cervical vertebrae, attached to the external occipital crest and external occipital protuberance. Next is ligamentum intertransversarium. It connects the apices of the transverse process of adjacent vertebrae. Okay. Now next is the spinal cord. In spinal cord, the morphology of spinal cord is 8 cervical, 12 thoracic, 5 lumbar, 5 sacral and 1 to 3 segments of the coccygeal. Now what is the function of this? Conducting sensory and motor impulse, participating in reflex function. There are 3 meninges. Dura mater, which is also called as pachymenix, which is dura mater spinale. Arachnoid matter, arachnoid spinale. Pia mater, spinale. Now this arachnoid matter and pia mater is also called leptomeninges. Now this dura mater, it is two thick layer are there and inelastic dense membrane. Outer is endosteal, inner is meningeal membrane. Now intermeningeal spaces, there is epidural space, subdural space, subarachnoid space. Epidural space is between dura mater and vertebrae. Dura mater and vertebrae. Subdural space is between dura mater and arachnoid matter. And subarachnoid space is between arachnoid matter and pia matter, where CSF is present. Fine. Now next is epidural venous plexus. Now this venous plexus is present between vertebral canal between two layers of dura mater in epidural spaces. It connects with vertebral plexus with lumbar vein and tributaries of inferior vena cava and superior vena cava by making cava-caval anastomosis. Now we move on to the A.V. Vishnevsky paranephral blockade. Why it is done? Hepatic and renal colics, occlusion in vessels of lower limb and dynamic intestinal ileus. Now mechanism is the renal plexus is located in the renal hilum. Okay. Along the pathway of vessels and nerves, Novocaine solution is given. It will reach the vegetative plexus of abdominal cavity, for example celiac plexus, and block the pathological impulse from the plexus. Procedure is: patient lies on an unaffected side with some cloth placed under him. Leg and unaffected side is flexed at the knee joint. Affected side is stretched. Now 60 to 80 ml 0.25% Novocaine solution is given. Point between erector spinae muscles and 12th rib and moved to paranephron. Now correct criteria of this procedure is: needle in paranephron, it moves up and down with the movement of the diaphragm during the respiration. Novocaine can pass through the syringe easily. If blockade in the syringe, solution drops out. Now next is lumbar puncture. Now lumbar puncture, it is done for meningitis or stroke. Contraindication is intracranial pressure is raised. Purpose is take CSF for diagnostic and therapeutic purpose. Procedure is: now inferior to the end of spinal cord, like conus medullaris, between the third and fourth lumbar vertebrae, patient lies on one side. Needle is inserted between the spinous process of third and fourth lumbar vertebrae in upper direction. If the needle is proper place, CSF will be clear straw color and would drop out. Epidural and subdural anesthesia. Now procedure of this is: anesthesia solution injection is given. Epidural space and spread along the loose alveolar connective tissue of epidural space. Afferent impulse are blocked. Spinal nerve passes through this space. Subdural anesthesia inject much deeper. Next is laminectomy. Laminectomy is surgical removal of the bony arch of one or more vertebrae. Now why it is done? Pott's disease, which is tuberculosis, spondylitis or spinal caries, prolapse of intervertebral disc, removal of foreign bodies, for example bullet, fracture or dislocation of the spine which requires reduction of internal fixation. What is the procedure? Patient is in prone position or lateral position. Head is lowered, minimizing the flowing of CSF. Center of the table is raised and lumbar region is made convex. Now, general anesthesia with tracheal intubation is given. Vertical incision is made in midline of the back. Length of the incision depends on number of lamina to be removed. Incision is done deep into the spinal process. Okay. Knife is kept close to the bone and muscle fibers are removed from the spinal process as well as lamina. Now broad bladed osteoma is detached muscular aponeurotic fibers from the lamina. The hot moist gauze is packed into the gutter between spinous process and muscles. It is used to stop the bleeding. After some time it is removed and retractor is applied. This procedure is done on another side of spinal process also. Now the spinous process, supraspinous and intraspinous ligaments are divided. The lower lamina is removed by bone cutting forceps by making a hole. Then exact dural fatty tissue is seen, which is moved aside to see the dura mater. With fine hook, dura mater is elevated and nicked with scissor. Sometimes the spinal cord remains adherent with the dura mater at the site of lesion. So if dura mater is opened at this site, it may cause injury. A grooved elevator is inserted through opening of dura mater and opening is enlarged. Generally, arachnoid is incised with dura mater. Now we move on to the topography of kidney. In topography of kidney, we would see the morphology. There are two histological parts, cortex and medulla. There are two poles, superior, inferior, and two margin, medial and lateral. Histologically, there is cortex, medulla. Poles are superior, inferior, medial margin, lateral margin. What is the function? Filtration, reabsorption, excretion, production of erythropoietin for erythropoiesis, and participation in RAS, angiotensin, aldosterone system. Holotopy is superior pole is projected on right and left hypochondric region and inferior pole in right and left lateral abdominal region. Remember, superior pole is in right and left hypochondric region and inferior pole is in right and left lateral abdominal region. Skeletotopy is 12th thoracic vertebrae to 2nd lumbar vertebrae. The 12th rib is divided the right kidney into superior 1/3 and inferior 2/3. Now 12th rib, it divides the right kidney into superior 1/3 and inferior 2/3. And left kidney, it is divided into two halves. Now syntopy of right and left kidney and left kidney. Superiorly, there is right adrenal gland and liver. Left kidney, there is left adrenal gland, stomach and spleen. Inferiorly, there is loops of small intestine and right colic flexure below the hilus. And on left side, there is only loops of small intestine. Anteriorly of the right kidney, there is transverse mesocolon near the hilus. And left kidney, anteriorly, there is transverse mesocolon, pancreas, left colic flexure and loop of small intestine. Posteriorly, there is psoas major muscle, quadratus lumborum, transverse abdominis muscle, medial and lateral arcuate ligament and diaphragm. And posteriorly, here also there is psoas major muscle, quadratus lumborum, transverse abdominis, medial and lateral arcuate ligament and diaphragm. Medially, there is descending part of the duodenum, and laterally of left kidney there is spleen and descending colon. Artery is renal artery and vein into inferior vena cava. Lymphatic drainage is para-aortic node and colic lymph nodes are present, and nerve supply is renal plexus, which is a branch of colic plexus, and sympathetic fibers T10 to L1 and paracolic fibers from vagus nerve. Capsule and fixation of the kidney. Now for capsule, it is fibrous capsule, adipose tissue is there, and renal fascia and retrorenal fascia are present. Now fixation of the kidney is done by renal fascia, psoas major and quadratus lumborum muscle, renal vessels, hepatorenal ligament, phrenicocholic ligament of the left kidney only, phrenicocholic ligament of the left kidney only, and duodenorenal ligament and intra-abdominal pressure. Now topography of adrenal gland. There are two histological parts, again cortex and medulla. Function is secretion of glucocorticoids, mineralocorticoids and androgens in the cortex. Secretion of adrenaline and noradrenaline in medulla. Holotopy is projection right and left hypochondric region. Skeletotopy is 11th, 12th thoracic vertebrae, 11th or 12th. Syntopy is right adrenal gland, superior pole of the right kidney, liver, inferior vena cava and diaphragm is there, and left adrenal gland, superior pole, left kidney, stomach and diaphragm. Arterial supply, superior suprarenal, which is a branch of inferior phrenic artery, middle suprarenal, which is a branch of abdominal aorta, and inferior suprarenal, which is a branch of renal artery. Now pay attention. Adrenal gland, there are three branches: superior suprarenal, middle suprarenal, inferior suprarenal. Superior suprarenal, it is a branch of inferior phrenic artery. Middle suprarenal, which is a branch of abdominal aorta, and inferior suprarenal, which is a branch of renal artery. Venous drainage. Right suprarenal gland which drains into inferior vena cava. Left suprarenal gland drains into left renal vein and then into inferior vena cava. Lymphatic drainage is lateral aortic node and nerve supplies suprarenal nervous plexus. Next is topography of abdominal aorta. In topography of abdominal aorta, the abdominal aorta is located below the aortic hiatus and it is divided into right common iliac artery and left common iliac artery at the level of fourth lumbar vertebrae. Okay, this abdominal aorta, it is divided into right common iliac artery and left common iliac artery at the fourth lumbar vertebrae. Its holotopy, it is located in the proper epigastric and umbilical region. Skeletotopy is first to fourth lumbar vertebrae. Syntopy is anteriorly there is celiac and aortic plexus, body of the pancreas, horizontal part of the duodenum, partial peritoneum and root of mesentery. Posteriorly there is vertebral column. On the right there is inferior vena cava, thoracic duct and cristae chyli. Left there is ascending part of duodenum, sympathetic trunk and azygous vein. Superiorly there is left renal vein. Now branches are two types, parietal and visceral. Parietal is all paired 1 to 4. First one is inferior phrenic, second is lumbar, third is median sacral and fourth is right common iliac artery. So parietal are inferior phrenic, lumbar, median sacral and right common iliac artery. Now this inferior phrenic artery which gives the branch to the adrenal gland, superior suprarenal branch. Okay, now visceral, there is paired and unpaired. Now what are the first one? Paired, middle, suprarenal, renal and gonadal. What are those? Visceral, paired. Visceral paired are middle, suprarenal, renal and gonadal. Okay. In gonadal, there would be testicular artery in males and ovarian artery in females. Now what are unpaired? Unpaired are main branches are celiac trunk, superior mesenteric artery, inferior mesenteric artery. Now in the celiac trunk, there are sub branches. What are those? Left gastric artery, common hepatic artery and splenic artery. Now celiac trunk, which is unpaired branch of visceral part of abdominal aorta, celiac artery gives left gastric artery, common hepatic artery and splenic artery. Common hepatic artery comes from celiac trunk, splenic artery comes from celiac trunk and left gastric artery comes from celiac trunk. Okay. Next is superior mesenteric artery. Superior mesenteric artery, there is inferior pancreatoduodenal artery, inferior pancreatoduodenal artery. Okay. Then next is intestinal arteries. Inferior pancreatoduodenal artery, then there is intestinal arteries, then ileocecal artery. Okay. Right colic artery and middle colic artery. Right colic artery and middle colic artery. Okay. Superior mesentery gives middle colic artery, right colic artery, intestinal artery, inferior pancreatoduodenal artery and ileoceliac artery. Next is inferior mesenteric artery. Inferior mesenteric artery gives left coliac artery, sigmoid artery and superior rectal artery. Fine. So we would summarize the abdominal aorta. Abdominal aorta skeletotopy is L1 to L4. It is in, see, this is proper epigastric, this is umbilical, L1 to L4. Okay. Now this gives branches which is parietal and visceral. Parietal are all paired. Okay. All paired. What are those? Inferior phrenic artery, lumbar artery, medial sacral and right and left common iliac artery. Fine. Now next is visceral. Visceral is paired and unpaired. In paired, it is middle suprarenal, renal, gonadal. Gonadal is testicular and ovarian. And unpaired are celiac trunk, superior mesenteric, inferior mesenteric. Celiac give gastric, hepatic and splenic artery. Superior mesenteric give colic artery, right and medial, intestinal artery, infrapancreatoduodenal artery, ileocecal artery. Inferior mesenteric gives left colic, sigmoid artery and superior rectal artery. Fine. Next we move on to the topography of inferior vena cava. In the inferior vena cava, it is formed by right and left common iliac vein at the L4, lumbar vertebrae 4th. Carries deoxygenated blood from the lower part of the body to the heart and passes through the caval opening, foramen vena cavae, and enters the right atrium. Holotopy is projected in proper epigastric and umbilical region. Scalotopy of the veins into inferior vena cava at L4. Syntopy is anteriorly posterior surface of liver, horizontal part of the duodenum, postportal vein, head of the pancreas, right testicular artery, right ovarian artery, parietal peritoneum, root of the mesentery and hepatorenal ligament. Posterior superior, there is right crus of diaphragm, right renal artery, middle suprarenal artery, inferior phrenic artery and right colic ganglion. Posteriorly, the vertebral column. Right is right adrenal gland, left is thoracic duct. Tributaries are parietal, right and left lumbar vein and inferior phrenic vein. And visceral is hepatic vein, which is right gonadal vein. Visceral is right hepatic vein, right gonadal vein, lumbar vein, right renal adrenal vein. Okay. Now we move on to the topography of lumbar plexus. Now this lumbar plexus, it forms T12 to L5. Okay. Now anterior to transverse process of lumbar vertebrae and lodges in the psoas major muscle. Now branches are muscular branches to psoas major, minor and quadratus lumborum, lateral intertransversarium muscle and iliopsoas muscle of. Now next is first branch is iliohypogastric nerve. Iliohypogastric nerve, it starts lateral edge of the psoas major and reaches the anterior surface of quadratus lumborum muscle. It muscle branches external and internal oblique muscle, transverse abdominis muscle, pyramidalis muscle and inferior part of rectus abdominis muscle. It gives anterior cutaneous branch to skin above the pubic symphysis and lateral cutaneous branch skin to the supralateral surface of the thigh. Now, next is ilioinguinal nerve. Ilioinguinal nerve starts lateral edge of the psoas major muscle, passes down to the inguinal canal and exits the superficial inguinal ring. Muscular branches gives to transverse abdominis, external oblique and internal oblique muscle. Cutaneous branch gives to skin of pubic symphysis, superior medial surface of thigh and inguinal region. Anterior scrotal nerve is skin to the root of penis and anterior part of the scrotum, and anterior labial nerve is skin to the upper part of the labia major. Okay. Now next is genitofemoral nerve. It pierces the psoas major muscle and divides into two branches, femoral branch and genital branch. Femoral branch, it gives below the inguinal of Pupert. Genital is skin of upper middle surface of thigh and superior inguinal ring into male and female. Cremaster muscle, membranes of testicular in male and round ligament and labia major in female. Next is lateral cutaneous nerve of thigh. It moves from lateral edge of psoas major muscles over the surface of iliac muscle and lateral to the anterior superior iliac spine, which innervates the skin of external surface of thigh. Next is femoral nerve. It appears through the lacuna musculosum and go lateral to the femoral artery. Muscular branches are quadriceps femoris, sartorius muscle, pectineus and tensor fascia lata. Now this lacuna musculosum we have studied already. When there is inguinal ligament, below the inguinal ligament, arcuate pectinate, it divides into musculosum and venerosum. So femoral nerve is in lacuna musculorum. Okay. Now the anterior cutaneous branch gives to skin and anterior medial surface of thigh. Saphenous nerve travels in the adductor canal and gives rise to infrapatellar branch, skin below the patella, medial surface of knee and above the tibia. And medial cutaneous nerve of thigh, anterior posterior surface of leg till the foot angle. Obturator nerve, it gives through obturator canal and gives rise to posterior branch and anterior cutaneous branch. Posterior branch gives to adductor magnus muscle, adductor minimus muscle, capsules of the hip joint and periosteum of posterior surface of femur. And anterior cutaneous branch gives adductor longus, adductor brevis, adductor minimi, gracialis, pectorius, abductor externus muscle, and skin of the lower half of the medial surface of thigh. Now next is operations of the kidney and ureter. Now there are two methods, Fyodorov's and Bergman's method and Pirgov's and Bergman's method. Now in Fyodorov's and Bergman's method there is access to the kidney, and Pirgov's and Bergman's method there is section of the ureter. Now first one, Fyodorov's method, incision is done at posterior angle between the erector spinae muscles and 12th rib, continues to anterior and interior to anterior superior iliac spine as far as anterior axillary line. In Bergman Israel's approach, incision depends upon the individual case, types of operation, degree of adiposity, and breadth of spaces between the last rib and iliac crest, above the parallel to iliac crest and inguinal ligament as far as abdominal inguinal ring. Next is the nephrectomy. This is done for malignant tumor of kidney, pyogenic infection, renal hypertension, renal tuberculosis, hydronephrosis, urolithiasis, hemorrhages of the kidney. Patient lies on the abdomen. Endotracheal narcosis is given. Approach is oblique lumbar incision by Fyodorov's or Bergman's approach. Fatty tissue is separated and its adhesion and cicatrices are dissected. Kidney is taken out from the wound. Renal vein, artery and posterior wall of the pelvis and ureter is isolated. Dishcam's ligature needle is used for two firm silk ligature under the renal vessels with 1 cm distance from each other. First ligature is tightened and placed near the vertebral column. Second ligature is tightened and Fyodorov's renal clamp is applied between ligature thread and renal hilus. Vessels are intersected between clamp and renal hilus. Okay, I will explain this once again. First of all, when we isolate the renal vessel, artery and posterior wall of the pelvis and ureter, then a Discam's ligature needle is used to put two firm silk ligature under the renal vessels and 1 cm distance from each other. We need to put a ligature under the renal vessels, okay, with a distance of 1 cm. Now first ligature is tightened and placed near the vertebral column. Near the vertebral column, first ligature is placed and tightened. Now second ligature we need to tighten and we need to do tightening, and then Fyodorov's renal clamp is applied between ligature thread and renal hilus. We have used a ligature thread, right? So between the renal hilus and ligature thread, vessels are intersected between clamp and renal hilus. Artery is intersected first and then vein. Clamp is placed 2 to 3 cm below the outflow of ureter, and below the clamp catgut suture is applied. Between the clamp and suture, ureter is intersected and kidney is removed. Iodine solution is applied to the stump of the ureter and plunked into the soft tissue. Rubber drainage tube is used. Bed of the kidney after carrying hemostatic procedure. Wound is sutured layer by layer. Next is nephrotomy. In nephrotomy, it is used for hydronephrosis, pyelonephrosis, calculi in the kidney. Methods is nephrolithotomy and nephrotomy. Nephrolithotomy is open renal parenchyma and removal of calculi, and nephrotomy incision is made. Now there are two methods, complete and partial. Nephrotomy. In partial, it is widely used and more important. Small area of renal tissue is cut and hemorrhage from the wound is less. Complication is unlikely. Incision in the renal parenchyma 1 cm from the midline of convex margin of the kidney. Wound is stitched by catgut suture. Next is nephrostomy. Persistent drainage of kidney and improved function. Indication is renal failure, pyelonephritis, severe course of calculus is pyelonephrosis. Incision is made on the renal pelvis. Insert a finger to the calyx. Small incision is made on the cortex. Probe is introduced to make contact with the finger and guide through the pelvic incision. Extend end of the catheter, cut to form bevel and attach to the silk stitch to the probe. Probe is drawn out through the cortical incision and pelvic incision is closed by suture. Next is nephropexy. It is done in nephroptosis. Indication is significant displacement of the kidney, hemorrhage, pyelonephritis, and renal hypertension. Pelvis and uterus are examined to exclude any organic obstruction of urinary outflow. Kidney is stitched with quadratus lumborum muscle and placed as high as possible by the 12th rib. The kidney is placed lateral part of the muscle with 3 stitches. Sheath of polyvinyl alcohol sponge is placed between the kidney and muscle to promote adhesion. Now next is exposure of the ureter. Upper end of ureter, same incision used in kidney exposure, done in stout point to prolong the incision forward and downward. Exposure to the iliac portion by extraperitoneal route. Patient lies on the back with head slightly lowered. A roller is placed below the pelvis on affected side. Incision is made fibers of the external oblique muscle with 3 to 5 cm medial to anterior superior iliac spine. External oblique muscles and aponeurosis are split. Internal oblique muscles and transverse abdominis muscles also split along the line of fibers. Branch of the deep circumflex iliac artery is ligated. Transversalis fascia is divided. Peritoneum is divided from the fascia covering the iliacus and psoas muscle. Ureter is elevated from the vessels. Along the peritoneum, it easily recognize and isolate, especially when it is thickened by some pathological process. Now, if a stone is located in the pelvic portion, ureter should be displaced upward to be more accessible to facilitate the stitching of the wound in the ureter. An incision in the ureter should be in the longitudinal axis and subsequent drainage of the wound is required. Now, exposure of the lowest 10 cm from the ureter. It is extraperitoneal method is also applied in this case. The access may be gained through any oblique incision. It is also necessary to prolong the incision medially by partly dividing the rectus sheath and retracting the rectus abdominis muscles medially. With the patient placed in the Trendelenburg position, the access may be gained through a medial hypogastric incision. The blade is exposed and retracted. Bladder is exposed and retracted. And the peritoneum is divided from the wall of the pelvis. This operation must be conducted carefully in the female to avoid injury to the uterine vessels. Now, sutures of the ureter is with fine catgut sutures through the wound of ureter can closely suture efficiently. It is advisable to provide drainage for external wound. So here we complete our lumbar region. Next would be our pelvic region. So thank you. Keep watching, keep learning. Bye bye.